Interprofessional collaboration starts with interprofessional education. When medical and healthcare students receive training on how to work effectively as a team across disciplines, they're primed to collaborate this way in the workplace. Interprofessional collaboration amongst medical and healthcare professionals provides benefits for both the patients and the professionals. These benefits are the following: empowers team members, closes communication gaps, enables comprehensive patient care, decreases readmission rates, promotes a team mentality, and promotes patient-centered care, leading to better patient outcomes.
So my name is Alison Rowe and I am currently employed at Whakatane Hospital as a palliative care nurse practitioner. I was very lucky because from a very early age, I only ever wanted to be a nurse. I don't know why, but I think from the age of 4 or 5, I always told people I wanted to be a nurse. I don't think I even knew what a nurse was. Nobody in my family had anything to do with health. Maybe I reflect back and think my grandmother died at home and the GP used to come up and visit her and so on. She had metastatic breast cancer. And I wonder about the influence of that because I was around 4 when she died, and it's the only thing I can think of, but I've never wanted to do anything else. My scope of practice as a nurse practitioner is an advanced nursing role. The role of nurse practitioner is I think it fills a gap and in lots of different ways, and people think it's kind of weird to have a nurse practitioner sitting inside a DHB inside the hospital, but actually you know, and even I thought that at first. I wondered about what the role would be in a hospital when I trained to be a nurse practitioner, but actually it does give you a lot of scope. It allows you to discuss with all other colleagues actually with a degree of confidence around the nursing. So you bring a sort of a meld of nursing, but you've also got the pharmacology and so on. So you bring a difference. It's not that often people worry about, well, why are you just being many doctors or whatever, but actually it's a lot broader and it's expanded nursing role. And so I am delighted to see so many more nurse practitioners now, especially in the community, and so it definitely has this scope of practice I think is here to stay, and I think it adds to our health system. In some ways I don't express the whole scope of my role in the hospital setting. For example, if a patient's already been examined by the medical team, you know, in the morning or whatever, I wouldn't go and re-examine them unless it was something I specifically wanted to look at myself or to suss out myself. And the same thing with prescribing. I tend to give advice and I don't often write on the drug charts and things myself. It's a teaching hospital, you're an advisory service and so on. So as opposed to having clinics and things like that, which many nurse practitioners do, where they prescribe a lot, I give a lot of advice and I write evidence for my prescribing, but in terms of writing on the charts and things like that, I don't particularly do that a lot myself. Maybe things like clinics are something we could do in the future. What are the challenges? Encouraging people to understand the full role of what palliative care can offer. Like, it's not just about the end of life, it's about a holistic approach, it's about early intervention. Many people sit in this hospital that could have palliative conversations with a palliative care nurse a lot sooner than they do. So it's different for me because I've come from 13 years of working with a palliative care team, which involved SMOs, registrars and other nurses, and so I came from a big team to Whakatane Hospital where I am on my own, although my palliative care team are in Tauranga. So I'm used to having teams, so what I've done is I've kind of more created my own team here, and I work really closely with the physicians, mostly the physicians and the RMOs and the nurses on the medical ward. The surgical ward I go to a bit, but not so much, so I kind of have created, so I see my team as, you know, like the OT, the physio, the educator. I've just made them all my team, really. So I feel like I'm part of this is a small hospital, everyone knows everybody, and I feel part of that team and an accepted part of that, yeah. palliative care is inherently centred around patients and whānau, because intervention should be tailored to what the patient wants. So first of all, you need to go and find out from the patient, what do they know, what do they understand, and what are their values, and what are their hopes and dreams, and what do they want for themselves. And until you understand their perspective, you actually can't be offering anything. Everyone is so different, and so you can't have a blanket approach. It has to be very patient focused. And when you look at this area, there are huge challenges. There's the isolation, there's a paucity of services in the community, and so all of these things have to be taken into consideration in tailoring the needs of the patient. You know, is this a patient who understands how to take elixir, or is this someone that you have to give a tablet to because otherwise it's just going to swig from the bottle and you're not going to know how much they take? So it's kind of like working alongside what works best for them and accepting that everybody's got different views. So it's quite funny in a way, because in the big hospitals you have a written referral, and I'm a bit of a thorn in the side for my colleagues in Tauranga who like to see the referrals come in because they come in electronically on your phone and so on. But you know, like if somebody stops in the corridor and says, can you go and see Mr. X? I'm not going to say, oh no, send me a written referral. It's a tiny place. So sometimes the nurses will ask me, sometimes other healthcare professionals, but I would always go back to the treating physician and check with them. Are you okay for me to see this patient? I've been asked by, you know, somebody or other. Or if a person's known to the hospice, then often I will just say, look, I know this person's known to the hospice, or I've known this person on a previous admission, shall I see them again? But I would always, you know, they are under the treating physician. We are an advisory service, so I would always check in whoever referred. But it can come from anybody. The resilience of people, and I have worked in a rural setting before myself, and what I found was, you know, that people would just find ways to get things done. You know, instead of having a mat or something on the bed, they would use plastic bags, or people would dip people into a bath in a bed sheet. You know, things that people in town would never think of because they're so used to having everything at hand. Folk that work in the rural community or live in the rural community have to be resilient and think about things in a different way. If I have a sadness, it's about that people don't present early enough to hospital. You see people coming into this hospital with advanced disease at a young age, and there's something around the barriers for those folks. So as much as I see resilience and coping and amazingness out there and the strength of whānau, I also see the barriers of the healthcare that we provide here that seems not to meet a great deal of the sector. And things like, you know, the cost of an ambulance to hospital at $98, just beyond what people can afford, or not being able to pick up your medications because you can't afford it. Those sorts of things, that inequities are. So that's what I've learned about this community, especially the inequities. But thinking about sending people home with an emergency plan and knowing that actually, whereas in town, you know, they've got people at their fingertips, people to ring, people to support them, people to go out after hours, and we could put a night nurse in, for example. Here we can't do that, and so there's a big responsibility on families to give medications, to make assessments, and we ask an awful lot of people without giving them a lot of education and support, I think. A lot about the inequities, and the people that I work really closely with are the Māori Health unit here, and I find them amazing. So what I notice is that sometimes I might go and see a Māori family, and I can tell straight away there's just a feeling that they're not looking to engage with you, or people don't make eye contact, or everyone's sort of plastered around the walls, and when you look around nobody really connects with you. I would say who I was then, and then I would go away and ask one of the Te Pōkōkiri to come with me, and they would then go before me and explain my role, and then I would come with them behind. And the difference is like day and night. It's kind of like having these support is amazing. So I work very closely with them. In that scenario, I would go out and ring one of them to come with me. Other times I would just check in with them to come with me. So I very much work with them. Some of my suggestions, I might suggest that somebody has karakia every day, or that we ask the Māori Health Unit to come and do karakia with a family. And I cannot begin to know all of the complexities to cultural needs. That's what's incredible to me, like the generosity of people to share the culture and to explain and so on. And I had this amazing young man who gave me all these books that I should read and explained all this this way of being and thinking and so on. So generosity, I'd have to say, that's what I've learned. And I've learned in terms of the Māori health model is that the model that we practice in the way we do health does not, I don't believe, meet the needs of Māori.
Nurse practitioners have advanced education, clinical training, and the demonstrated competence and legal authority to practice beyond the level of a registered nurse. They provide a wide range of assessment and treatment interventions, ordering and interpreting diagnostic and laboratory tests, prescribing medicines within their area of competence, and admitting and discharging from hospital and other healthcare settings. Many nurse practitioners work in primary care where, like general practitioners, they may be the lead healthcare provider for the client and their whānau. Some nurse practitioners own their own practice, others work for district health boards, non-governmental organisations, or for Māori and iwi providers. Nurse practitioners are more likely to work in rural areas and in underserved communities. Currently, there are now more than 300 of the skilled practitioners working around New Zealand.
On the way home. So where have we been, Hari?